Thank you. Thank you, Chairperson. Thank you, Gansi sir. Thank you, Sanjeev Patak sir and Dr. Manoj Chawla sir for inviting me here. I'll be talking about cardiac autonomic neuropathy, especially in diabetes. This is a kind of different topic what we are clinically uh, learning the clinical aspect of heart and diabetes at present. But in this symposium, I will shift it from another hall. So I'll be talking about the basics, why it is important, and is there a way we can use this? I would try to simplify the methods to assess and use in our clinical OPD, where the complicated instruments are still difficult to apply in our OPD. Basic, I will be skipping, autonomic nervous system in our body has two parts, sympathetic and parasympathetic. Simple words, sympathetic nervous system activates our body, where parasympathetic prepares our body for rest and digest. The functions wise, we know sympathetic system is for fight or flight system. It increases the heart rate, it increases the sweating, dilates pupil, inhibits GI movements, closing all to sphincters, and it diverts blood from non-essential organs to the essential organs. Uh, on the other side, parasympathetic nervous system is for rest and digest system. It promotes digestion via peristalsis. It slows the heart rate, it constricts the pupil, and empties the bladder, relaxes the sphincters, and it also mediates the genital rejection. So we won't be talking about the diabetic gastropathy, bladder involvement, peripheral nervous system, but we will be focusing on cardiac autonomic neuropathy, where the autonomic nerve fibers are damaged that innervates the heart and the blood vessels, in turn causing the abnormalities, especially in heart rate and vascular dynamics. So this is what we'll be discussing. There are two main parts, subclinical, where patients are unaware, clinicians are unaware. Only when we test it on the cardiac autonomic reflex testing machine, like based on the heart rate variability, baroreceptor sensitivity changes, and cardiac imaging, it shows abnormality, which is called subclinical can, where clinical is where it is diagnosed with sympathetic activity is predominant and symptoms such as reduction in the exercise tolerance and resting state tachycardia are evident. That we call starting of the clinical phase of the CAN. So why are we discussing cardiac autonomic neuropathy? We must have very rarely heard this topic in various conferences. But why we are discussing what is the importance? Because appearance of cardiac autonomic neuropathy correlates with dysglycemia, both the level of dysglycemia and also the duration of dysglycemia. There is the effect of bad legacy, what we call, usually coincides with other complications. Once your patient has cardiac autonomic neuropathy, you can assume he might have other complications of diabetes itself. If you see, after 5 to 10 years of diagnosis, there is up to 25 to 50% mortality. In simple words, 5-year mortality rate is 3 to 5 times higher if patient has autonomic neuropathy compared to diabetic patient who doesn't have cardiac autonomic neuropathy. Is it common? Yes, it is varyingly reported. We see across the studies across the world. The subclinical dysfunction is very common, but it is undiagnosed, and especially undiagnosed in our country. And symptomatic autonomic neuropathy occurs but long after the onset of diabetes, and very uh, occurrence rate, if you see, 2 to 91% in type 1 diabetes and 25 to 75% in type 2 diabetes. So what are the risk factors? As we discussed, poor glycemic control and long duration of diabetes. There are other associated factors like increasing age. Female gender may have increased risk of CAN in type 2 diabetes, but not in type 1. Higher BMI, smoking and elevated triglyceride have also been associated in some paper. If you see the occurrence, the racial differences, this uh, cardiac autonomic neuropathy is similar in both South Asians and Caucasians. So what can be the mechanisms? These are simple. I will not simple. These are similar to what we have seen with the peripheral neuropathy also, which we discussed more common. Similarly, glucotoxicity by polyol pathways also, advanced glycated end products also, then hexosamine pathways where glucotoxicity damages the nerve fiber. Similarly, lipotoxicity, oxidative stress, ultimately which reduces the synaptic transmission and it also increases the apoptosis, and inflammation is also part, we have seen with the other complications of type 2 diabetes. So there are initially structural changes and functional changes. So what are the structural changes? These are progressive land-dependent neuropathy, predominantly affecting the vagal nerve initially. So vagal nerve is the first to be affected. Then second thing is the full length affection of the vagal nerve. Then it progresses to sympathetic plexusis, and then ultimately both parasympathetic and sympathetic neuropathy occurs with fibrosis. Functional part, what is the first one? There is sympathetic predominance in early cardiac autonomic neuropathy, and later on parasympathetic. Loss of blood pressure circadian rhythm is one of the earliest changes. Unopposed sympathetic tone with resting tachycardia, and then postural blood pressure decrease is seen in advanced cardiac autonomic neuropathy. So orthostatic hypotension, once it occurs, we can label it as an advanced stage. What can be the clinical manifestation? The simple words, heart rate variability, we will be discussing. And there is resting tachycardia, and in later stages, there is a what we call fixed heart rate. Patient heart rate doesn't change, no, very negligible changes in the later or advanced stages. Blood pressure, BP changes, we know there are non-dippers. You must have heard the word non-dippers, no, blood pressure monitoring and 24-hour ambulatory BP monitoring. So what we see in cardiac autonomic neuropathy, first thing will be nocturnal hypotension or non-deferred. Then there is orthostatic hypotension when the patient stand up, some supine or sitting. There is a fall in blood pressure, and or there is also a term called postprandial hypotension. Okay, you must have heard a term called respiratory sweating. Okay, right? Another autonomic neuropathy, but we won't be discussing because we have huge topic. But similarly, there is postprandial hypotension also. Okay? And one of the common symptoms described by our patient in OPD is the limited exercise tolerance. थक जाते हैं, काम नहीं हो पा रहा है. This is one of the reasons where the sympathetic nervous system is affected more, and the clinical outcome is patient feel fatigue and there is limited exercise tolerance. Otherwise, there are QT prolongations also. Why we got silent MI in diabetes is the reason because of the cardiac autonomic neuropathy. Now the heart becomes, the simple one, denervated. There are no signals carried out by the cardiac nerves, so the pain is not felt by the patient. So this is a simple word, silent MI. There is a term called diabetic cardiomyopathy. You must be seeing in your 2D echo reports where is the actual dysfunction. Later on, without any reason, you see reduction in the ejection fraction. So this can be a part of diabetic cardiomyopathy. Very important aspect, we see intraoperative changes when the patient is having cardiac autonomic neuropathy. No, there is increase in the need of vasopressor support during anesthesia, and there is sometimes severe intraop hypothermia also with the patient having cardiac autonomic neuropathy. These two are very important features we should not be neglecting, and there is increased risk of stroke also. These are all sometimes if you see the pathophysiology, they are associated with peripheral neuropathy, but remember, do not substitute the stage for peripheral neuropathy. Like, we see the monofilament tanks or sensory testing we do commonly in OPD. We should not replace this cardiac autonomic testing with this simple test because they cannot discover the cardiac autonomic neuropathy. So there is no single approach for simplifying the test. I was changing. I'll change them to simple things. For parasympathetic, just we have to see the heart rate responses, the deep breathing also or slow breathing, standing from the supine or sitting position, and then Valsalva maneuver. For sympathetic activity, we need to measure the blood pressure responses to standing and isometric exercise. This is simplified. I have done this test. So for heart rate response, you need either a dedicated machines, but if your institute has a ECG machine with live reading, okay, there is a screen where ECG is continuously being shown on the screen, and the RR intervals are shown on the screen. You can use these. So in simple word, patient lies down and takes very slow and deep breathing, so 6 breaths per minute. So every 10 seconds he completes one inhale and exhale, and you see the RR intervals during expiration and inspiration, and you see the ratio, and difference in heart rate of less than 10 beats per minute is abnormal. So in simple words, when you take inspiration, you must remember in the physiology days, your heart rate goes up. When you expire the breath, your heart rate goes down. The ratio is not that much if you have cardiac autonomic neuropathy. Similarly, heart rate also you need to understand uh, uh, to standing when patient is lying supine, and then patient is stand up. The RR interval measured at beat 15 feet and 30 beat, and you can see the ratio less than 1.03 is abnormal. So these are again machines with that. I will take 5 more minutes. If you allow, because my talk has been 15 minutes, but it has been cut down to 10 minutes. But let 5 minutes, 2 more. Yeah. So there are autonomic function testing labs also, and these are the advanced tests like heart rate variability, power sector analysis. One Let me add this slide on. I shouldn't skip it. The blood pressure response, very, very simple thing you can measure in your clinical OPD. That is, patient is lying down and for 2 minutes and he stands up for 2 minutes and then you check the blood pressure, both supine and standing. And if you see the systolic BP fall more than 20, it is significant, and diastolic BP falling more than 10, it is significant. Very, very simple test. This is what we can use. And BP response to isometric exercise. We have handheld dynamometers where patient squeezes it, and we can see the maximum pressure he can squeeze, and the 30% of the maximum he need to hold for 5 minutes. So there is, this is what we call isometric exercise for labeling it. And if the diastolic BP doesn't decrease, which normally increase more than 16 millimeter, but it doesn't increase above 16 millimeter, it is abnormal. So these are lab tests, and there are advantages just for research only. We cannot do. Safety-wise, whenever you are doing Valsalva manure, which I have skipped due to lack of time, and there is a theoretic possibility of intraocular hemorrhage also, especially if your patient has proliferative diabetic retinopathy, and children and mentally disabled agents, they are difficult to perform for them, and it is for us, it is very time-consuming, and there are sometimes accessibility and cost issues. So prevention, yes, we have seen there are so many papers also which shows the cardiac autonomic neuropathy begins with pre-diabetes also as compared to patient with normal glucose tolerance, NGT patient. So it is prevalent from the beginning, and if your patient loses weight and follows the lifestyle, we can revert to normal glucose tolerance along with reversal of the cardiac autonomic neuropathy. But once it develops, the strategies can be based on the main cause and symptoms of the patient. For glucose toxicity, we need to have good lifestyle changes and good blood glucose control. For lipotoxicity, for we need to have lifestyle also and good blood glucose and lipid control also. Similarly, for oxidative stress, along with lifestyle, we can give antioxidants like alpha lipoic acid, vitamin E, and we can give phytonutrients. For inflammation also, we can give microbial inhibitors also. For sympathetic overactivities, okay, the anti-adrenergic beta-1 anti-adrenergic receptors like non-specific like ethanol can be given. ACE inhibitors are also there, which sometimes via the another feedback mechanism reduces the sympathetic flow. For orthostatic hypotension, we have alpha-adrenergic agonists, okay, like midrodin and clonidine. Clonidine are commonly used in India but have some side effects. We can use cholinesterase inhibitors, and our friends we frequently use plasma expander, okay, which we know fludrocorticoid, which is mineral corticoid kind of steroid, which expands the plasma, which ultimately reduces the chances of orthostatic hypotension. Even some of the patients who are on antihypertensive, using them will reduce the risk of orthostatic hypotension. For impaired heart rate variability, for prolonged QT intervention, again, it is a cardiologist subject. I usually refer them, but we can use magnesium and isoproterenol for chronic, and sometimes they need spacing also. And for sudden cardiac death prevention, if the patient is eligible criteria, we can use ICD. Orthostatic hypotension, very important thing. Uh, General measures work wonderfully. We need to teach our patients to change the posture very slowly and in very stages, tensing the leg and dorsiflexing the leg and doing some exercise before standing up, and sometimes doing hand grip also reduces the chances of falls. If the patient can tolerate and there are injection fraction is proper, we can allow them to have high salt diet and water consumption also. We need to treat anemia also. The important thing, we need to avoid drugs causing oxidative hypertension. Two commonly used drugs, SGLT2 inhibitors. Dr. Ghosh sir has mentioned the wonderful drugs of the century, but we need to be cautious, especially when using in elderly patients, to avoid oxidative hypertension and fall. And diuretics, Dr. Tripathi also mentioned. Uh, Sorry. So the initial speaker also mentioned about the diuretics in heart failure. There are stocking and gravity suits for very, very severe orthostatic hypertension. Drugs, I've already mentioned. And to summarize, it is very common but undiagnosed stage. It is progressive disease, and diagnostics testing can be done with cardiac autonomic refresh tests, which are based on heart rate, but availability and our time consuming and cost is an issue. And using this and treatment strategy very important. They are very limited once the patient is diagnosed, and it is just to prevent the progression with good glycemic control, and for symptomatic control we can use the drug. So I thank you. I'm overshooted by 5 minutes, but I completed in 15 minutes, which was allocated. Thank you, sir.
Thank